Hello, everyone, and thank you for joining us this evening for the third week of the RISE Institute and Rugby Research and Injury Prevention Group 2026 Major Joints Anatomy and Pathology Series. We will begin our first presentation. Our first group to present includes Jordan and Brendan. Jordan will be presenting on the anatomy of the hip, and Brendan will be presenting on the pathology of hip replacement, hip labral tears, and snapping hip syndrome. You both may introduce yourselves and share your screen when ready.
Okay, I'm gonna share my screen. My name is Jordan. I will be presenting on the anatomy of the hip, and
My name is Brendan, and be presenting on hip replacement, hip labral tears, and snapping hip syndrome.
okay. So the hip is one of the most important joints in the body. It connects the leg to the pelvis and allows us to walk, run, jump, and move in a lot of different directions. The hip is a ball and socket joint, and the ball is the head of the femur, and the socket is called the acet acetabulum. Because of this shape, the hip can move in many directions while staying stable. And one of the most important things about the hip is that it has to balance movement, both movement and stability. It needs to move enough for activities like running and sports, but it also needs to support the weight of the whole upper body and lower body. So to understand the hip in its full glory, it's important to first look at the bones that make up the joint. The main bones are the pelvis and the femur. The pelvis is made of the ilium, the ischium, and the pubis, and these bones come together to form the acetabulum, which is the socket of the hip. The femur, also known as the thigh bone, has a rounded top called the femoral head, and this is the ball that fits into the acetabulum. Other important parts of the femur include the femoral neck and the greater and lesser trochanter or trochanters. These areas are important because they provide places for the muscles to physically attach to, and the shape of these bones help make the hip super strong and a stable joint. And you can see in the diagrams where they attach and how the pelvis and femur attach right, or the femur attaches to the hip. Okay. In addition to the bones, the hip also contains several soft tissues that help the joint move smoothly and stay stable. So first we have the articular cartilage, which covers the ends of the bones and helps reduce friction when the hip moves. Another important structure is the acetabular labrum, which is a ring of tissue around the edge of the socket. The labrum helps make the socket deeper and keeps the femoral head in place. The hip also has a joint capsule and several ligaments surrounding it. These structures help support the joint and prevent it from moving too far in one direction or another, and they also help protect athletes during activities and people in general during activities such as running, jumping, pivoting, changing direction, and all of that. The muscles and ligaments around the hip are also very, very important for both the movement and support that it provides. The main ligaments include the iliofemoral, pubofemoral, and ischiofemoral ligaments. These ligaments help keep the joint stable. The muscles around the hip allow it to move in different directions. For example, the iliopsoas helps bring the leg forward, while the gluteus maximus helps move the leg backward during movements such as running or jumping. The gluteus medius helps move the leg away from the body and also helps keep the pelvis level when standing on one leg. The adductor muscles move the leg toward the center of the body, and all these muscles in general work together to help the hip move more properly and stay stable. Stay stable. The hip is able to move in many different directions, just furthering into that. So first, I want to talk about flexion and how it brings the leg forward, and extension moves it backwards. Abduction moves the leg away from the body, and adduction brings it back towards the center. The hip can also rotate inward and outward, and these movements are especially important in sports because athletes are consistently running, jumping, landing, pivoting, as I've mentioned a few other times. And in many sports movements, the hip is doing several things at once. For example, when an athlete changes direction, the hip may need to bend, rotate, and move from side to side at the same time. And because of this, the muscles and bones of the hip have to work together to control movement and protect the joint. So, to understand the anatomy of the hip is important because injuries can affect many different parts of the joint. Some common hip problems include muscle strains, dislocations, or um, and stress fractures. These injuries can make it difficult to walk, run, jump, or participate in sports. The hip also works closely with the knee and the rest of the leg, so problems with the hip can affect movement in other parts of the body as well, especially in the leg. The hip is a complex joint. It provides stability while the muscles, ligaments, cartilage, and labrum help it move. The hip must balance movement and stability, which is why understanding its anatomy is important for both everyday activities and sports. And then handing it off to Brendan.
I'll be presenting now on hip replacements, hip labral tears, and snapping hip syndrome. So hip replacements, they're needed when there is joint damage, arthritis, or hip pain. Some of the most common ones being osteoarthritis, which is just over time the grinding of between the cartilage and it diminishes it. And then there's rheumatoid arthritis, which is autoimmune, which degrades the cartilage between the antebellum and also the femoral head. So over time, this damaged cartilage over time needs a hip replacement. And there are two types of hip replacement, the most common being a total hip arthroplasty, which is the name for a hip replacement. This is a surgical procedure that replaces both the femoral head and acetabellum with a prosthetic. And there's also a hip hemiarthroplasty, which is much more rare, which is only the replacement of the femoral head. And this often happens when there's either a fracture in the femur or the femoral head while that hip socket is still intact. And this video is a diagram of a total hip arthroplasty and its procedure in 3D. So basically, they remove the femoral head and also the ball and socket, and they replace it with a prosthetic. And another popular injury that happens with the hip is a labral tear. The labral tear, as Jordan said before, is the cartilage and tissue that lines the hip socket. And often some of the symptoms of a labral tear is a hip pain when bending, moving, doing exercise or sports. And there's often stiffness and there's a popping when moving the hip. And some of the common causes of that is a femoroacetabular impingement, which I'll get to in the next slide, and often sports injuries when athletes are landing on their hip. It might lead to a labral tear. And some of the treatments that come with the hip labral tear are anti-inflammatory medications. There's also physical therapy that can help strengthen the muscles around it to help mitigate this labral tear, but this tear will not repair on its own. So the only way to repair this tear is through hip replacement or hip arthroscopy. And the most common cause of labral tears is femoral acetabular impingement. And this is basically when the hip joint doesn't really fit together due to excess bone. There are three types: the cam impingement, which happens on the femoral head when there's excess bone. On the diagram on the right, it illustrates that. And there's also a pincer impingement, what happens on the pelvis, and there's excess bone that causes the pressure when moving, which leads to a higher rate of labral tears. And there's also combined impingement, which is both cam and pincer impingement combined. And often athletes are more likely to experience these symptoms because of how much they move around and use their hips during sports, that they often will feel this pressure on their labral and cause a lot of discomfort. And the treatment for from this impingement is the same as a labral tear, going through physical therapy and anti-inflammatory medications, but the only way to remove these kind of impingements is through surgery. And there's a test for this, is a FADAR test, which three parts. There is flexion, which is the first part, which you bend the knee, and then there is adduction, where you rotate the knee more inwards, and then third part is internal rotation, where you rotate the foot outwards, but it rotates your hip inwards. And a positive test would you would feel a pinching near your hip when doing this movement, and that would be considered a positive test for femoroacetabulum impingement. And lastly, the snapping hip syndrome, also known as Cox's Saltons, or also called sometimes dancer's hip. And this is experiencing a snapping or popping every time you move your hip. There are two types. There are external snapping hip and internal snapping hip. From external snapping hip happens on the outside, and this is where your iliotibial band or IT band rubs against your femur, and this is what causes the feeling of a snapping or popping. And then for internal snapping or popping, it's the iliopsoas tendon, which rubs against the pelvis or the femoral head, and this is what causes the snapping or popping that when it comes to internal snapping hip. And often this is caused by tight tendons or muscles, as tight tendons and muscles cause more of a rubbing in against the bone. And there's also causes of cartilage issues, injuries when it comes to sports, and also variations in hip joints, like as abnormalities happen. And often athletes are at higher risk for snapping hip syndrome because of how much they move and use their hips during exercise, that these muscles around it will often tighten and cause this snapping hip syndrome. And the treatment for it is obviously rest and recovery to help loosen and relax these muscles. Also, physical therapy can help to help strengthen the muscles around the hip, and obviously anti-inflammatory medication. And in serious cases where movement is very restricted and it's hard to just do basic walking, surgery and arthroscopy is suggested. And these are our references, and thank you all for listening.
Thank you.
Thank you, Brendan and Jordan, for that presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
No, it's very comprehensive. Thank you very much. I think also the use of the videos are clearly explanatory and evaluating impingement. Also evaluating the actual total hip arthroplasty. Obviously, the acetabulum needs to be drilled out, and then the total hip needs to be placed into the femoral, shaft. Obviously, the biggest problem is the amount of pressure and hammering that in, and possibly, or avoiding cracking the femoral bone. Anyway, great job. Thank you very much. That was very interesting. None of that, including the various sports topics. Sports pathologies.
Thank you, Dr. Lopez. If we don't have any questions from our interns, our second intern group includes Julian and Alan. Julian will be presenting on the anatomy of the shoulder, and Alan will be presenting on the pathology of the rotator cuff tear repair, shoulder dislocation, and acromioclavicular joint injury.
Can you all
Okay,
see?
perfect.
Yes. Okay.
So hello, my name is Julian. I'll be presenting on the anatomy of the shoulder. So first, we can look at the bones that make up the shoulder. The shoulder is formed by three bones that work together: the clavicle, scapula, and humerus. The clavicle, or the collarbone, connects the arm to the trunk and helps support shoulder movement. The scapula, or the shoulder blade, is a flat triangular bone that contains important structures like the glenoid fossa, where the humerus attaches. And the humerus is the upper arm bone. Its rounded head fits into the glenoid fossa to create the main shoulder joint. And together, the clavicle and the scapula form the shoulder girdle, which anchors the arm to the rest of the skeleton. But although these bones provide like a wide range of motion, they can't work on their own and they're naturally unstable. So they rely heavily on the surrounding soft tissues and ligaments for support. Next are the joints and ligaments that allow the shoulder to move. The main joint in the shoulder is the glenohumeral joint, which is a ball and socket joint and it's the most mobile joint in the body. The acromioclavicular, or the AC joint, connects the clavicle to the acromion of the scapula, while the sternoclavicular, or the SC joint, connects the clavicle to the sternum. The scapulothoracic joint isn't a true joint. It's often referred to as a false joint, but it allows the scapula to glide smoothly around the rib cage. And the shoulder also has a joint capsule, a labrum, and several ligaments that help stabilize the joint while allowing it to have a large range of motion. And finally, we can look at the movement of the shoulder. The shoulder performs 6 primary movements: flexion, extension, abduction, adduction, and internal and external rotation, as can be seen in the diagram, where the arrow represents the arm and the shoulder represents, the dot represents the shoulder joint. When these movements are combined, they create circumduction, which is the circular movement of the arm. And another important concept is scapulohumeral rhythm, which is the coordinated movement between the scapula and the humerus. This coordination allows us to perform smooth overhead movements like reaching or throwing, where we can move our arm in a large variety of directions around our shoulder. And overall, the shoulder's unique design provides good mobility, but that flexibility also makes it more susceptible to injury.
I will start with presenting on the pathology of the acroclavicular joint. Okay, so as Julian mentioned, the acroclavicular joint refers to the joint between the clavicle bone and the acromion of the scapula. This can have many different injuries at this joint. Most commonly are shoulder dislocations, which I will explain later. But it's classified by disruption to the acromioclavicular ligaments or the coracoid ligaments. And as you can see in these photos here, the coracoid ligaments connects the clavicle to the coracoid process, and the AC joint connects the acromion to the clavicular. The epidemiology of the causes of these injuries is usually a direct blow to the shoulder or sustaining a fall. It will happen by pushing the shoulder blade back from the collarbone. Some symptoms are tightness, swelling, loss of motion at the top of your shoulder. And if the clavicle disconnects from the ligament, it can form a bump at the AC joint. There will be pain when lifting your arm above your head, across the body, or away from the body. Some complications from this injury are arthritis, and the term for the arthritis at this joint is distal clavicle osteolysis, which can also come from different injuries, not just from a AC joint injury. People most at risk are athletes and males aged 20 to 30. And the best way to prevent this injury from happening is to strengthen and stretch the joint. To see if you have this injury, doctors will do a bilateral radiograph, which will look for internal widening. As you can see in this photo, the clavicle is much above on the right side than it is on the left side, which means that the ligaments aren't holding the clavicle and the acromion joint together anymore. You can also do an AC joint compression test if visual imaging isn't available. To treat this injury, doctors will prescribe immobilization and rest, meaning that you won't be able to move your arm so that it can heal properly. And they can also prescribe anti-inflammatory injections. Shoulder dislocations are one of the types of injuries that can cause an acromion injury or AC joint injury, but it also can have many other characteristics to it. So as Julian mentioned, the shoulder joint is the 3 bones coming together: the scapula, the humerus, and the clavicle. And a shoulder dislocation happens when the humerus is no longer in the glenoid cavity. The shoulder has triaxial movement, which means that it can move in all 3 planes. And so when the shoulder gets dislocated, it can also be dislocated in 3 planes. It can move forward, backwards, or downwards, and it usually happens in forward dislocation. The ligaments, tendons, and other soft tissues that keep the joint in place can also be affected by this injury. Usually this injury is caused by sudden force, especially at the front of the shoulder, which will push the shoulder back, or extreme twisting. The shoulder will often look out of place and there will be swelling and bruising, as well as pain when moving the shoulder, and your muscles can also spasm. As you see in this top photo here, the shoulder looks very much out of place and it also is not symmetrical to the other side. So there is good evidence that the shoulder is dislocated. Some complications for shoulder dislocations are that ligaments and tendons can tear, and there can also be damage to the nerves and the blood vessels surrounding this joint. One of the most common complications is damage to the glenoid cavity cartilage, which often creates that you can have multiple shoulder dislocations. So in this photo, you can see that the glenoid cavity cartilage is broken and fractured, which can lead to being able to have multiple shoulder dislocations. Some common risks are if you play a lot of sports, especially contact sports like football, hockey, and rugby, as well as sports with falling, so gymnastics, volleyball, etc. If you also have a fall risk, you're also at risk for shoulder dislocation, and it's most commonly seen in teens and people in their 20s. So as mentioned before, if you dislocate your shoulder once, you're at risk for it to happen again because you have worn down the cartilage and the tendons that keep your shoulder in place. The best way to prevent a shoulder dislocation is to wear protective gear when playing sports and to exercise regularly to build strength, flexibility, and mobility. To diagnose if you have a shoulder dislocation, usually you can tell, but if needed, you can also do an X-ray. In this top photo, you can see how the head of the humerus is no longer in the glenoid cavity, and it's very easy to see. To treat this, most doctors will do a closed reduction, which moves the joint back into place. But after that, you will immobilize the joint, do rehabilitation exercises, and rest and ice the joint as well. In the bottom photo, this is one of the ways that you can reset this joint. There are a lot of ways, but this is the Mitch maneuver, which you move the arm up and away from the body to gently, not exactly gently, but put it back into place. Lastly is the rotator cuff tear and repair. The rotator cuff refers to the four muscles that surround the shoulder and the tissues and ligaments that support it. The four muscles are the supraspinatus, infraspinatus, subscapularis, and the teres minor. These muscles help your shoulder abduct and external and internal rotate. The tendons will be the most affected. They are attached to the muscle. It's not common to see a muscle tear with a rotator cuff, but the tendons will most definitely be affected. It usually happens to the supraspinatus tendon, which is right here. This injury can develop over time. It is common to see in people who are older just because of the wear and tear of having that motion, but it can also develop earlier if you have repetitive movements. You can also have this injury by falling on an outstretched hand, also known as fouche, and you can have complete rupture with the shoulder from a shoulder dislocation, or if you're lifting heavy and your body just can't handle it. It's classified on the size of the tear, whether it's partial or complete. And some symptoms are limited movement, muscle weakness, and pain. Some complications with this is that your muscles can atrophy, meaning that they will disconnect from the tendon and the bone and will move back. And your tendons can also retract, meaning that they won't be in their original insertion point. And you'll have to go in through surgery to reconnect it. Some risk factors, as mentioned before, it does affect older people, people aged over 40, as well as males and workers and athletes who use a lot of overhead use. So construction workers, bodybuilders, football players, rugby players, anything like that. Again, there's not much to prevent a rotator cuff tear, except for strengthening and stretching the joint and making sure that it is in its most it has the most integrity. Some current ways to test for a rotator cuff tear is the Job test. That's the most common, as well as the drop arm test, infraspinatus injury test, bear hug test, and liftoff test. If tests are inconclusive with those, you can also do an MRI. In the top photo, you can see the Job test. The doctor will turn the patient's arms, they will supinate it, and they will press the arms down so that you can test if the ligaments are still attached. Treatments for this are shaving off the bone spurs. Bone spurs are these little growths on the bone, which can have a lot of wear on the tendons if not treated. And they can also go in if the tendons have atrophied and retracted, they can reattach them. Some non-surgery ways to fix a rotator cuff tear, if it's not as serious, are anti-inflammatory drugs and steroid injections. Here are our references, and thank you for listening.
Thank you, Alon and Julian, for that amazing presentation. Are there any questions from any of our interns, or Dr. Lopez, do you have anything to add to that?
Yeah, the classic pathology for the shoulder dislocation obviously is impact or collision. And then obviously you'll find this on any the standardized exams. And then did they discuss the posterior dislocation versus anterior, Elon?
There was some slight discussion, but I didn't highlight it in it. They just
So
mentioned that you can't have it on either side.
it'll most likely be electrocution or lightning to get past all those muscles in the back to give you a posterior dislocation. So that's your test question, like on USMLEs and that. Probably on your boards as well if you're doing physical therapy. So posterior will be due to electrocution or a lightning strike. And then anterior dislocation will be from impact or collision on the shoulder from a sports. And those will be the two case studies that you'll probably see. What they did discuss obviously labral tears, and there's also hill sacks, and a lot of other injuries that occur with the dislocation, with the shoulder, because there's so many aspects to it. When you get past the, when you dislocate it, you could scratch the humeral, humeral head, and obviously get, hill sacks, get scratches into the cartilage on the surface of the head. And these are very common, very painful, very difficult to deal with, as well as destroying the glenoid, the labrum of the glenoid fossa. And obviously that's what they repair to give you better stability. And they also look at it in a clock dial face, 12 o'clock, 3 o'clock, 6 o'clock of where the labral tear is and its repair. Obviously, superior lateral, labral tear, things of that nature are multi-directional. So that means if you got tears in quite a bit of it, what they do is they suture over the labrum tissue back and anchor it to the fossa, so this way it can redevelop that ball and T aspect. So your glenoid and your labrum is very, very small, and then your head falls right on it. And that's really the kind of vision that they kind of give you to show you what the stability of the humeral head is on the glenoid fossa and the labrum. And when they repair it back, they also sometimes now do capsulorrhaphies or heating up the capsule to tighten it a little bit, or maybe even tightening the capsule up with sutures, depending, what they do, surgeon type. This will give you more stability in the joint, obviously, to help stabilize a joint, multi-directional instability, or multi-directional instability in the joint line there. All right. Thank you very much. That was very detailed. I appreciate it.
Thank you to all of our presenters. That will conclude week 3 of the RISE Institute and Rugby Research and Injury Prevention Group 2026 Major Joints Anatomy and Pathology Series. Thank you all for attending.